Jen wishes a good afternoon.
She can say.
So this is Senate Appropriations, and we're continuing our testimony on the fiscal 2024 budget. And today we're taking testimony from Commissioner of the Department of Health Access, which is one of the very large budgets in state government. And so we have two documents here. One is the ups and downs, and then the other is the slide deck and then oh, that's Agent Starry. And then this, which actually is a very helpful walkthrough and explanation of everything that's happening within the budget. So with that, Commissioner, if you want to introduce yourself and other staff, that I see you've got Tracy here to make sure your testimony is accurate and aligned with the administration's position. So,
Thank you very much. I've left my baggage.
I am.
Thank you, Madam Chair. Nice to see you all, members of the committee. Thanks for having us here today. For the record, my name is Andrea DeLabriere, Commissioner for the Department of Vermont Health Access. Joining me today online via Teams is Allison Nowak. Allison is a financial director in the DIVA business office, and she'll be helping to present the narrative and ups and downs today. For your information, Patrick Rooney has left us, unfortunately. So Allison has graciously volunteered to step in and help, which she's very knowledgeable about the budget anyway. To my left, we have Tracy O'Connell, Financial Director in the Central Office, the Agency of Human Services, and Ginger Irish, the Director of Communications and Legislative Affairs. So we're happy to be here today. Thanks for having us. We're here to present our FY24 budget. And it's important for you all to know that the approach to the budget process this year was a little different than it has been in past years. There's a whole agency approach to the budgeting process, which resulted in resources and money, dollars, to be directed toward areas that needed it more so than they could have benefited from in the past, or could have had access to funds in the past, and also resulted in the departments having somewhat less discretion in the other areas of the budget that we would normally have some increases. So you will see that reflected in the budget as we walk through, just to level set everyone's expectations there. Today we're here to
be like the man who said he didn't expect much for Christmas and he didn't get as much as he expected. So that might be where we are on this budget. So we understand the secretary laid it out yesterday.
Thank you.
So we understand
Thank you.
What's being presented here and why.
Perfect. We are requesting nearly $85 million in new gross appropriations for this FY24 budget cycle, and I'm going to hand it off to Allison for a walkthrough of the narrative, and we'll pause intermittently to allow questions and dig into any.
So before we start, obviously we've just finished the budget adjustment, and we had to have some significant modifications as a result of the revised caseload and PMPM. So in terms of obviously what drives this budget is caseload mobilization. And could you just, before we start this, no, you don't need to apologize for delivering another message. That's Senator Childress. You can tell.
Yeah.
And she's very sweet. So can you just give us an update on the match and what's happening there in terms of the assumptions you're using in 24, in terms of your Medicaid match?
The case loading list. Okay. Sure, so I will try, and then I may ask for phone a friends to my left and on screen. But the public health emergency, as we all know, has been in effect since 2020. So we have been in a holding pattern in terms of Medicaid determinations for almost 3 years now. That is a federal law, and because of our ability to keep people enrolled in Medicaid, we have received an additional enhanced FMAP of 6.2% at the agency level. Over time, this will be phased out beginning on May 11th. We will begin redetermine, is that May 11th effective date, Tracy? For the FMAP piece?
For the 6.2?
Yes.
It actually shifts to 5% beginning in the April quarter,
Okay.
and then 2.5% in the September quarter and 1.5% in the December quarter.
Okay, which is the first quarter of the federal fiscal year, but our calendar year, then by the end of this calendar year, it would be phased out then? Okay.
Yes. So backing that up a little bit, redeterminations will begin in April.
Okay,
The formal public health emergency end will be May 11th, but it's uncoupled from the redetermination aspects.
okay. And that redetermination, you're not going to be doing redeterminations and attempt to do eligibility reviews on how many thousands of cases that you currently have. Are you staging in terms of either category types?
Yes.
Give
Give you a little bit more background there. Happy to do that. Thanks for the question. So we will begin redetermining eligibility for all 208,000-ish Vermonters. I can't remember the exact number now, but we have had 22% growth spurt, if you want to call it that, over the last 3 years in terms of our enrollment. What we try to do, we have a very thoughtful plan, a comprehensive plan. We have a lot of public information available about it, which we can share with this group. One of those is a one-page flyer with a front and a back to be able to be shared with constituents, which has been well received. But we are trying to per month, there will be a number of individuals who will be predetermined, and we have a threshold that we cannot go beyond in terms of, we've been working very closely with CMS on this aspect, and over the next 12 to 14 months, we anticipate having the whole population predetermined in some way, shape, or form. We expect many of them will be eligible for qualified health plans as well, and the enhanced subsidies have really helped that effort right now. With the Inflation Reduction Act and the subsidies being extended for 3 years, it's been very, very helpful in terms of helping people afford their premiums for health insurance. The nice thing I think about the way Vermont is structured is that we have Medicaid and the health insurance exchange in the same department. So there's a seamless transition, whereas in other states, that's not the case. So we're hopeful that many of these folks will be eligible for insurance.
So when you're doing redeterminations, are you doing it by eligibility group? Are you doing it
So there's
across different populations, or are we trying to start with the ones that their eligibility is probably the one where they are going to be terminated, they're no longer eligible?
That's a great question. So we're really beginning with the folks we are have pretty high insurances that will have access to a qualified health plan to make that transition a lot easier. I would say that in the shortest summary, we are prioritizing individuals that have access to other means, other health insurance first, and deprioritizing other individuals who perhaps, for example, with the postpartum extension, may become eligible during that period, do not want to disenroll them during the time when they would be eligible for additional coverage. So we would not focus on that group, but yet we're trying to be very thoughtful about the process. We have, we anticipate a number of folks will not be eligible, either based on financial eligibility or some other citizenship related eligibility issue, but we can't project how many of those folks at this point. would not be eligible.
Well, when we were looking, last year, didn't we do, anticipating that reviews were going to commence, that I think we tried to estimate the amount of money being spent on, households that were gonna exit, and therefore the cost was gonna go down. So I just was wondering, how that might influence this.
Well, I think we're in the best possible position. I mean, there's no way to be sure, but I think we're in the best possible position we could be in right now, having access to the subsidies that are quite generous.
All right, well, why don't we keep going then? So obviously, Medicaid is fairly complicated. So let's go through the budget requests.
Great, thank you very much. So Allison, I'm going to hand off to you at this point to walk us through the narrative, and we can stop for questions as we go. Can you just state your name for the record, Allison, please?
Yes, my name is Allison Novak. I am a financial director in the Department of Vermont Health Access, and I'll be presenting DVHA's request for 2024 Governor's Budget Recommendation. And this request has a gross amount of 85 million, which is 33.5 million of that is general fund. The 85 million sum is comprised of administrative appropriation of 20.6 million and a programmatic appropriation of $64.3 million. And I am sharing the narrative as well, and I'll be scrolling through the narrative as I talk about each individual section. So the first section that we're going to start with is a salary and fringe, retirement and healthcare changes. This equates to $2.6 million gross and a $1.5 million general fund impact.
Yes, I remember when the office had about 50 employees, and we thought that was big.
It's bigger now.
373.
Huh?
370.
Yeah, 373. Okay. So this is salary fringe retirement, change. Internal service.
Yes. So this relates to DVHA's recruitment efforts in trying to compete with the private sector in the collective bargaining agreement, along with healthcare and pension cost increases for the agency. We're projecting no change in full-time equivalent positions of the 373 full-time employees, and the breakdown is reflected below in the table between salary and fringe and retirement expenses. Continuing on to the Internal Services Fund, also known as ISF, which has $140,000 gross impact, of which $29.9 thousand is the general fund component. As you can see, these are shared services throughout the agency and departments as they share in covering the cost.
Yeah, we see all the budgets, so we understand. These are not negotiable. This is what you're being billed. So.
Correct.
Oh,
Correct.
You just did that in budget adjustment.
I should, I would be remiss if I didn't mention that you will see some common themes that you saw in the BAA. This is one of them. And it's a big driver of,
Could you explain number 4, 17 million for
yes,
Medwas?
happy to do that.
That's
I think 3 and 4 would probably be
Oh, is
reasonable
this
to
the new
pers-
MMIS?
it's improvements to prepare for an event last. So
Who's your fiscal intermediary right now?
I'm sorry,
Is your fiscal intermediary right now?
Gainwell,
Okay, well,
and they have been so for decades, about 40 years.
I remember Ross Perot. We had PBS. So
This is the preliminary, buddy.
it seems like
What
it's
are we
awful.
looking at for the whole system?
These are great questions. We don't know the projected.
But this is 0 state. So is this federal? So you've done advanced planning document and you're getting 100% federal on this?
So the carry forward dollars that we discussed back in the BAA testimony, those are the state fund component.
So there is state fund, it's carry forward as opposed to asking for a new appropriation. So what's the carry forward here? Well,
The 3.8, I believe, was the carry forward.
it seems like an awful lot of money.
But how much is the whole project?
So back,
The entire state budget, I think.
Might
This
be,
way.
if this is preliminary.
right, so we're under contract discussions right now, which is why I can't share a lot of information, but these are estimated project costs. And 3 and 4, items 3 and 4, and I'll kick it back over to Allison shortly, but these are in tandem. So if we think about the system as a whole, Gainwell is our fiscal agent, they're our claims engine, they process 7 million claims a year, for example.
Yeah.
In order to have other components work with Gainwell, we need to do enhancements to the Gainwell platform, which is the 654 that you see in line 3. So if you
Oh,
move
this is
down-
a new term, a data lake. Would you?
Yes.
Oh, my gosh.
The cloud.
So we want,
cloud, we got the lake.
we don't have,
We have a
we
lake, a
don't
warehouse,
have
and a cloud.
orientation anymore. We have onboarding. We don't have wheelhouse. It's now space. I mean, it's very hard keeping up with this.
We used to have a sea of
So what-
paper, now we've
So what
got a
is
lake
it?
of
What is
data.
the data lake?
So a data lake at the very highest level is data that's unstructured. So it's data that lives in this one single space that is then extracted to become meaningful in a reporting world. So we have a
It's
lot
my
of.
brain. Don't you, Andy? Don't you think?
You mean the junkyard?
Yeah, my junkyard. I think it's now a data lake.
Great, yeah, that's exactly
Yeah,
how I
you
feel.
have a
about
very
myself.
large data lake.
So the data from the data lake would then be transformed in another space to be able to be extracted and become meaningful in reports, analytics, all the things that we need to do.
What did it used to be
compliant.
called before a data lake?
Good question. They've always been data lakes. Do either of you have any
Data
background? I don't think there was a thing before a data lake. That there's a data warehouse, which is this project for what you see the acronym MD was. We love to put names to our acronyms here at the state of Vermont.
The data warehouse was that. Did that predate any of these systems or? we talking-
No, so this is newer development, modernizing, steps forward to modernize the existing technology. So the data warehouse is structured data. So data lake,
And I'm not
unstructured,
gonna get
messy.
an answer to how much it costs.
Is there any relationship
Right.
between unstructured and structured and aggregated and disaggregated?
There's lots of difference, lots of difference.
I think Senator Lyons probably has some sense of that.
Oh, well, I'm trying to figure it out, but I.
As
it
an
does begin to make
academic, I
sense.
bet you do.
I do, it does
Yeah.
make sense.
Yeah. All right, well, it's a pile of money.
It is,
And,
it is. And it's an ongoing, so I think that Senator Westman, I think what might be helpful is, as we think about IT, some folks believe that at the end of it, you're going to get something. It's gonna be a something. In IT, it's really not that way. It's more of enhancements over time, and they live on in order to meet the demands of Vermonters, hopefully, is the goal. And those need to change as technology changes so fast in the world that we live in.
Well, you are gonna get more reporting and more analytical tools, and we are
That's
gonna
right.
get all of that.
So
So I quickly,
this data is gonna get worn out by the
I'm trying to
time,
figure out-
you know, because it goes to the health exchange. We're also moving it to OneCare. It's being used in so many different places, and are we paying for multiple systems to extract and you know, and use the data? It just raises a host of questions because the whole use of data and it's obviously been a topic of great concern.
Of course.
Certainly that came out when the Blues decided they didn't want to participate in OneCare.
They're doing the same thing probably.
They're doing the same thing. So
am I looking at 20 million a year though, forever?
20 million a year. Oh, you're talking about ND West. I don't know the answer. I don't believe so. This is more development aspects, not maintenance and operations, which comes after.
Okay, so is this part of? No, it's not part of it, but Diva was going to in the oversight committee, IT oversight on, so is this, this IT project, has that been subject to review by the IT, our oversight committee? I know the integrated eligibility was being followed. I haven't got a clue how well we're doing there yet. So, and integrated eligibility is not integrated eligibility, it's just Medicaid eligibility. So, is this, what are we paying now? Just in our Gainwell contract, our annual contract.
I can probably, I don't have that off the top of my head, but I'm happy to follow up.
All right.
Can I ask a question?
Yeah, go ahead.
So it's looking like it's both medical claims and clinical data. So is it a combination of things that we might see in Vital and we also might see in VCures?
Right, that's.
And so then that's being sorted out to give some context to clinical improvement and also financial efficiency. Is that how this is
That's
being
exactly
used?
right.
Oh, good.
So the idea is that right now we have access to claims data.
Okay.
Which is limited information, right? You don't have the insight that you would have in a medical chart, like a blood pressure or a lab result. And so.
So can we, and can
together,
we sort it, then is it being sorted, I mean, similar to the way we know Vital is sorting out clinical data based on condition, chronic condition.
Right.
And then we can figure out quality clinical improvements.
Exactly.
So we're doing that for Medicaid only.
Well, right now we're beginning with Medicaid. I don't know what the landscape will be later, but we really have control over Medicaid right now.
Okay. But it'd be great to integrate everybody.
I guess that's it. I mean, because some individuals are going to actually be duals, they're going to be Medicaid, they're going to be Medicare, and they could have in fact private insurance. And it seems like everyone is going to take the data and analyze it and manage that one individual. It's like, how do you synchronize the various efforts? Like OneCare is supposed to, and Medicaid has been the major participant in OneCare. And so what are we doing here that we're not already paying for in OneCare, which is data collection and care management?
Right. So this is a question that we were asking during the construction of S285, Part 2, and now it's Act 167. And so how do you, I think the language in the bills might suggest one repository, but in reality, what we're trying to do is to blend the data so that if you go in and you say, what's the best treatment for something, that all that data will fall out and you'll have that analysis in front of you from all the different sources. You could ask it of all the sources and bring them together. So right now, if
Who is the you, the pronoun?
she's
The
a
provider,
no,
the payer?
it could be. It could be the payer. Or it could be the Agreement Care Board, I don't know.
Well, it
Where
just-
does it, this is the final question.
Yeah.
The biggest question is, who's in charge of quality data analysis? Who's in charge of making that evaluation for clinical improvement and then sorting that information out back to the providers?
And mostly the payer is gonna say, I wanna be in charge because I'm on the hook for the cost.
Hello, and that
And
is
so-
exactly why Blue Cross and Blue Shield is doing it all by itself.
But then you run into the issue around, obviously, everyone is paying to support these systems. Those costs are getting embedded and covered somewhere. And I'm concerned about the person who in fact has coverage from multiple sources. And then how many different ways is their data and how many different entities are attempting to manage the care of one person? It could be very interesting. Well, this is precipitating quite a discussion.
Yeah, but it's great. I think it's good that it's in Medicaid's hands because Medicaid, it gives us an opportunity to maintain appropriate care for our most vulnerable,
And the most expensive.
and the most expensive. So, yeah.
I'm just connecting to the one care,
I know.
which we are paying for as well. So Andy.
In number 4, there's a quotation. What is that quoting?
Medicaid data warehouse and analytics.
The centralized repository.
So there's a quote, to quote, construct a centralized data model. So this is pulled from somewhere because it's quoted. I just wondered what it's pulled from. Why is it in
I don't know.
quotation?
Yeah,
Yeah,
well,
quotations.
Who are we quoting? Is that?
I just didn't know if there was like a plan, or like, oh, see, we planned this, so we're quoting from our plan. Or-
I don't know where that quote, I don't know why it's quoted, but I'm sorry, I don't know
It's okay.
the history there, but I can tell you that having a centralized repository, a one source of truth is also another way to say it, is very useful, because then you don't have disparate systems trying to talk with one another, and it kind of eliminates the errors.
So that might have come from 167, called the integrated.
Well, I think we'll go on to Office Friends. We can understand that.
Allison, back to you.
Well, we're gonna move on from that price tag to some cost savings that I have displayed here in reduction of office rent. This item does reflect a $489,000 growth and a $209,000 general fund savings. This item relates to some of the changes in the workplace environment over the last several years at Diva. We've been consolidating our physical footprint. An analysis was completed in the last few years of our rental spend for our budget and realized that we're not actually spending to our budgeted amount.
We understand. I know that the House likes you to get into great detail, but we understand exactly what's happening here, because I want to leave time obviously for number 7.
Sure.
So the reduction in space, I think that's self-explanatory, and operational reductions are, in the scheme of things, quite tiny. But if you go to 7, then you can see where the real money is, $62 million there. So I just, for the sake of time, I just want to make sure that we have time for the, unlike the House that has all day to do the budget, we have to do it in an afternoon, so.
No problem, no problem.
So I don't mean to cut you off,
That's okay.
your presentation, but I think probably we can move past 5 and 6 quite quickly and move to 7.
Program.
Yeah, to the program.
Sure. With that guidance, we'll dive right into the programmatic portion of our budget. Diva is requesting $64.3 million gross, of which $32.6 million of that is the general fund portion. This is the actual facilitation of the Medicaid program itself. So the caseload utilization section number 7 has a $4.5 million gross and a $2.9 million general fund increase. As we're merging from a time of continuous coverage onto the renewal process, which has been on hold since the PHE started in March 2020, with the redetermination, as we've talked about already, it's also known as the unwind, the number of Medicaid enrollees will start to come down. Every Medicaid member will undergo a renewal process, as it is a federal requirement. Diva we have 3 years of pandemic activity behind us, so it makes it very difficult for us to predict what the need will actually be. However, what's presented is our best estimation. The estimation is done via the consensus process, which is done in conjunction with the central office, JFO, and Diva coming together. And I'm going to scroll down just slightly. And
This
is
the forecast we accepted in January. I just wanted to relate this to some action that we had taken recently relative to the consensus. It's really a consensus caseload and utilization report. So
Gonna move on to number 8.
yeah, it's a lot of money. So the caseload, I've forgotten, in terms of caseload, we're going to be doing eligibility reviews. We think we'll be losing caseload,
Yes.
but in fact,
Over time.
over time, so the caseload over time will be lower in this fiscal year. the utilization must be up? Or is this a reflection of additional costs like your dental
We are
initiative?
seeing some increases in utilization.
So as the redeterminations take place and there's a decrease in the population of Medicaid, but there'll also be some 5%, you said 5% going down. You'll still get that regardless,
Yes.
so regardless of caseload. So
It's a phase
the
down.
faster we work on redetermination, the greater the income we have to. Is that true?
That's the goal,
Okay.
but utilization will have an impact.
Yeah.
Okay, should we move to number 8?
Well, I certainly don't think we can quarrel with the estimates that we already accepted.
Okay, great.
I wanna go back and revisit the keyboard decision.
How much
no.
time do you have?
All right. So now we're done with the Brattleboro retreat.
Yes.
Yes, the next 3 items, 8 through 11, are common themes relating to the Brattleboro retreat. The first one is the Brattleboro retreat APM year 2 appropriation shortfall. DEVA is requesting $3.6 million gross to bridge the shortfall in BAA. We're now building this need into the base budget for the existing contract. This ask carries a $1.5 million state fund impact.
So can
Number
you- the relationship here, because the retreat, I mean, the mental health department is, you're paying the bill and mental health is overseeing the care and the utilization of that resource.
We hold the contract, yes, and we work very closely with them for Medicaid members specifically, but
And so that per diem rate is gonna go from 25 to 31.
it
Yeah, we
has-
already approved
It
that.
has.
In the
It
BAA.
has,
we
we don't anticipate any increases in this FY '24.
And
Right.
how many per diem, how many, translate that into how many beds that would be?
I think that's
given?
51 beds. 51.
51. Maybe, oh, it's, 42 to 51, sorry, it's right there.
And that's the total number of beds, or is it?
Medicaid beds.
So you pay them all, whether they're saying by in them or not in them. Or do you-
To have them available.
Yes. And they're often full.
They are generally full. Although I'm surprised, is there a limit on the number of bed days that you can bill to Medicaid that are empty? For example, nursing homes have a time limit, I think 3 days. And so are we,
I'll have to look at that for you. I don't know the specifics on, I really want to say it's for 60 days, but I might be wrong. So I don't, let me follow up. That's okay.
all right, well, it's important to be looking at the utilization very carefully if we're paying for beds, regardless of the number being used. I suspect with the capacity issue within the mental health system, it's, probably fairly high occupancy, but
There is,
I
and
don't know
we're
what the occupancy.
monitoring very closely, certainly, but we can provide some more context around the approval, number of days approved. Okay, so these items are, I think they should look familiar to you from the BAA discussion. Would you like Allison to walk through those?
You mean for 10 and 11? No, we know the phase down, that's been required, that the, so.
Okay. Move on to
As we're
12.
phasing down the federal funds, we've got to gig up the state funds.
Right. Okay.
Annual rate adjustments.
Number 12, Allison?
Yes. Annual Medicaid rate adjustment. So this has a breakdown of $914,000 gross and $395,000 general fund. This increase is primarily related to the increase in qualified healthcare centers and rural health clinics. but there are several other areas that exist within the requested rate requests, such as professional services, outpatient services, and DME. This also does have a cross appropriation impact, which is displayed in the table below as well.
All right, so what is to translate that into a percentage increase to what that rate adjustment is for the various providers? 2%, 3%?
So the increases you see here are federally required increases. The proposal for other services are budget neutral.
I understand, I just
So-
wanted to translate in, what does that mean in terms of those providers? What that,
For FQHCs and
Yeah.
hospice providers.
I know that
It's
they're
very small.
very small. All right,
I'm going to continue on to number 13, which is the annual Medicare buy-in and caseload changes. This area reflects a $1.3 million gross and a $503,000 general fund component. There's little change in this caseload year over year, but in the state of Vermont, we have an aging demographic, which is driving the increased request for those dollars to be used on behalf of duly eligible beneficiaries. This is another item that also crosses appropriations that's represented in the table.
that's something we've been paying very long.
Can
So,
I
yes,
just to number 12, a quick question. What inflationary rate are you using? How are you calculating that?
it's very small and it was federally mandated. That's,
Oh,
I asked that
okay.
question, because I was saying, is it 3%, 2%? And-
Okay, that was the same question.
Yeah,
Yeah,
it's very, I think it's 2.1% is the mitigating economic indicator. But there are discussions in the BAA to bring that to 3.8, I believe.
That would be good.
discussions and,
The BAA process for FQHC specifically.
oh,
The index that you brought up, the
Yeah.
BAA,
The
you'll-
MBI.
but
That
this
will
is
be
on
the-
top of it, right?
that will have, you will have to add on top of that if you want to continue.
Correct.
Work.
Yeah, okay.
Okay.
We know that dental is a big, well, you're gonna have dental in several places.
Right.
So, this is for DS and CRT clients.
Correct. So
Why are we separating out dental services for this group, eligibility group? Is there an advantage here with federal funding?
This was an opportunity. in-
I could read the text, but since you're here, why bother?
Exactly, that's why I'm here. So this is an opportunity that we had available in the waiver, the 1115 waiver negotiation. And it allows these populations, the disability services populations and the community rehabilitative treatment populations to receive enhanced services, and essentially removing the $1,000 cap.
Is this a result, is that part, Stephanie, is this part of the overall enhanced match that we're getting from,
No, it's a separate,
it's separate from that budget that we can put together and we did for funding increases and stuff?
you mean the home case, so this is
Yeah.
separate from
It
that.
is separate.
All right, okay.
We do partner with the Department of Mental Health and the Department of Aging, Disabilities, Aging and Independent Living to be able to provide funds to then federally match and transfer money from those departments to allow for this.
We need to access the federal
Improves
dollars.
access, exactly.
This is a provision of the waiver,
Right.
All right, has nothing to do with that other.
which was ARPA related.
Okay, all right. And is this because of the difficulty sometimes of treating individuals that are disability or CRT is serious and persistently mentally ill, so I was just wondering why the federal government was giving a higher match. Is it because of maybe the difficulty of serving that particular population?
I'm not sure of the reasons why, but we're certainly happy to take advantage of the opportunity.
Well, yeah, we are too. I was just
Yeah,
wondering
I'm
why,
not sure.
why we're getting that. GME,
Number Number 15.
Number 15. So number 15 is the graduated medical education, the also known as the GME supplemental payment. So this is another theme that came from the BAA presentation, and we're requesting authority to increase the global commitment spending to increase the payment from $30 million to $51 million, which has a gross amount of $21.2 million and a $9.2 million general fund breakdown. And I'm happy to go into a little bit more about how GME works. Unless everyone is.
Who's covered under the GME?
Who's covered? So this is UVM Medical Center residents. It's a residency program. I'm sorry,
It provides funding directly to the residents.
to the University of Vermont Medical Center to then care for their salaries, other curriculum development things related to that. And this is essentially building it into our base budget.
And they're providing the match, so it isn't a, they are, so we utilize the match. I was just, that's a fairly significant increase to 51 million in terms of what it is that it's covering. Is this a capped, is there, or as long as UVM ponies up the money, we can draw it down, or if there's, what conditions come with this? And I'm just wondering, that sometimes if rules change, you know, we're building a very significant Medicaid presence here, and I'm just wondering, this is not a time limited provision.
Right, but you're correct, but there is a contract involved. And so we have a contract with the University of Vermont Medical Center, and they have outlined priorities, and they do this on an annual, I think on an annual or maybe it's every 2 years basis to outline where they're going to focus their efforts. One of them in the current contract, for example, is e-consults. So provider to provider consults over some form of technology.
Can we use this in any way to influence the primary care to encourage students to go into primary care? I'm just wondering, can we use this, is there any leverage here in terms of what the state needs and goals might be?
I think this is a great opportunity to expand the number of residents that they can take on in through their program. I think the questions about enrollment and where those providers go after residency is a question for the medical center and or UVM. It's a tough one, yeah, but.
Well, I know when we did some other, initially started doing the match with them, we have language in the budget, or when we did it, remember that we guarantee if.
That was the investment.
Yeah.
That's all been stepped down, I believe.
Okay.
From UVM's, but it still exists in the state college world for the allied health. But that was related to purely a financial general fund savings through
I know.
global commitment
And
investments.
I know, and but we had language that protected them, that somehow that we would make it up to them. They would not, they were being held harmless if it.
And in the end, they did get held harmless when
Okay.
that investment had to be phased down.
I see, okay, so that's already been done. All right, what's the cap?
I actually don't know what the cap is. We have not increased it in about a decade. It was from where it was $30 million. One is the first increase in about a 10-year period. I don't know what the cap is, I'm sorry. I can find out though.
Is this certified match, or how is that working mechanically?
It actually passes through the remnants of the state healthcare resource fund. So the UVM actually, there's a transaction.
Okay, I was just wondering, it's not like a certified match that we have in other areas. Andy, you had a question?
Well, just what's just in the 21 million total and the 51 million.
What, I'm sorry, what was your?
So on 12, so it's the budget up here, it says, you know, like the 21 million gross, but then but it's talking about an increase to 51 million.
Oh, right. So that's because that's the difference from 30 and the result.
It's just the increase.
Just
Yes. Yes.
With this, supplemental payment that have been offered, are there any strings on that money presently?
Only those priorities that have been outlined in the contract. So in terms of, where are you going with that? Are you thinking?
Well, in the past, there's the question of whether or not we could require the university to use funds, particularly in the primary care arena. They have always balked at anything, and they have suggested that the most placements that they could have is graduating sixth year. And have done that. So if, and that came directly from the university itself, because we've had that discussion even at this table. So my question is, with this, is there any ability to adjust this money and require anything more that's in the contract? And I don't need an answer
No,
for
I
that
think
right
that's
here.
to the extent to which we can leverage this matching capability, which they like, to advance some of our own healthcare goals.
Because,
These are good
you know,
questions.
quite frankly, if we've got a shortage of between 75 and 80 primary care doctors in the state, it would be helpful if they were graduating more than 6.
Yeah.
And, but I'm not really clear if we have any ability to do that. So it would be helpful if there was an answer to that.
I'm sure the
question.
Office of Primary Care would be good source to find out at UVM. And that's Charlie McLean. And well,
Maybe they wouldn't, maybe there's an opportunity, it's a great question.
and they're gonna say, well, we're putting up the money, so we want to define, but on the other hand, we're giving them access to a matching source, which is pretty valuable as well.
Very valuable.
Well, and if we're giving a cap for global commitment, does that limit us sometime in the future?
You know, I think that's a good question, because for a couple of years, we were really struggling with hitting the cap and very concerned about, we were told, well, if you do increases, you're gonna jeopardize, our flexibility relative to the cap. So I know you renegotiated some things with the waiver, maybe that doesn't have to,
That risk was reduced.
Yeah,
in
that-
terms of the.
yeah, but we obviously, as a result of that experience, have been kind of cautious about what we're using that capacity for. And in this case, it's nice, I mean, it's to their, but we want to be sure it's not at the expense of something else, that it's really essential to.
Well, and if there is some ability, if we have pretty much nearly a crisis in primary care in the state. So if there's any ability to get them more money, if we could nudge them along to do some more.
Right. I don't know what their capacity is or what their.
Right, that might play, it might play into it and all of that, but I don't, sitting here, I don't know how to ask that question.
Well, it's actually something that the Secretary's office should be doing, because it ties into, I would think the health resource plan, which, no, that's now done, it used to be health department, but now it's done by the board, right?
Which one? I'm sorry.
The old Harumph, is that now the responsibility of the Green Mountain Care Board?
Oh, the health resource allocation
Yeah.
plan is the Green Mountain Care.
Yeah.
Right. But the DOH still collects a lot of data.
Yeah.
And there's a debate about.
Well, you understand, from the agency level, that.
Those guys.
So we'll keep going here, because we have a group coming in at 2:40.
How would you like to spend the next 15 minutes? We have dental, we have a bargaining agreement, we have drug
Well, the
coverage.
bargaining agreement, we understand.
Yeah.
Obviously. The dental is a big initiative, and in terms of the increase, a very substantial increase.
Okay, so Allison, would you like to just briefly touch on the dental proposal? This is a governor's initiative, just a level set. That's why it's reflected in our budget.
This is gonna hit the wall of capacity. And that is, even if you can pay, so many practices are not accepting patients because they're already maxed out. Obviously, it makes, if you have a Medicaid card, more attractive to be at least paying a decent rate, but it's just the fact that we've got more demand for care than we've got practitioners to provide the care. So,
There's still a cap.
what?
There's still a cap.
So there's still a cap, but you had to adjust the cap if you're gonna give this kind of increase.
Well,
Otherwise, you blow through the cap within one visit.
yeah, what would you like me to address first?
Well, all of the questions that you're asking, in other words, I'm sure the dental society, you know, it's been a chronic problem for decades around which practices would accept Medicaid at all. And you had a limited number of practices and they were feeling exploited because they were goodwill, and then others were accepting no Medicaid. So obviously reimbursement was a big thing. The other part is no shows, also the difficulty of serving the population. But my question is, even with the dental rates, then how you adjusted, well, for children, if they need it, you can't have a cap, can you, because of EPSDT. So it's the adults that have the cap.
Right. So starting with the cap conversation. Right now, we're doing some analysis on what percentage of folks actually have hit the cap in the last few years, pre-pandemic too, because I think it's a better marker for evaluating. So we're in tandem with that. We're also doing an analysis on fiscal impact, which we imagine will be quite large of removing the cap.
But didn't you have to do that as part of this analysis?
No, we did not. This is really to close the gap between Northeast Delta Dental, which is the commercial payers we're using as a benchmark, and Medicaid rates.
I understand that, but the more rate increase that you're paying per service, the sooner you're gonna hit that cap. So the cap, a lot depends on how many people are hitting the cap, I suppose.
Right.
And what that utilization is gonna be. But it seems like you'd have to do that to say you need 13.1 million.
Well, I think we looked at it a little differently than that, primarily because we knew that not a high percentage of folks were actually hitting the cap, but we need to narrow it down to what is the actual percentage, and then monitor was what we were proposing to do at the time, and still are, essentially. What we need to do really, I think, is a fiscal impact on it to understand the full picture.
Senator Lyons.
So are you tracking what type of utilization is resulting from the increase? Will you be doing that?
In terms of access,
Yes.
yes,
Okay.
we
So,
have been.
so are there any conclusions that you're drawing from that?
So at the highest level, what we tried to do is we spoke with 260 different practices and tried to get an understanding of where were the barriers to care. We know one of them is workforce. We know another one are Medicaid rates. Another one of those issues are Medicaid rates. And the confluence of those is causing the problem. We know we're not going to fix the workforce issue with rates, but I think that will have an impact.
Well, I'm
It
sure
makes
it
more
will.
attractive.
And obviously, right now, it's a real deterrent to take. But my concern is if you don't adjust the cap, then people are gonna get actually fewer services for those that do hit the cap. Because the reimbursement is gonna just hit that cap sooner. So in the end, the people that might have the most acute need for dental care, in fact, are going to get less because if you don't somehow do some adjustment on the cap side.
Right, which I think is what, our intention is to closely monitor both of those things. We wanted to stabilize and prevent further erosion from patients being able to access dentists, as well as understand the impact of how many people are hitting that cap. And we're finding it's a lower percentage, but it doesn't mean that won't change as access improves and people get back to the.
But the people who are hitting the cap now are actually, and if they've got significant dental needs, they're gonna get fewer services because they're caused. Well, it's obviously a concern. I don't know what percent of the adults who hit the cap. I know.
We'll provide that as well as the fiscal.
I'm not even sure you could get a full set of dentures if you have just someone that's dentulated, but who knows? What is the cap?
$1,000.
$1,000. I know some of the practices, they schedule you in December and then in January, so you can pick up, 2 years of what?
When you have major work.
Yeah, when you have major.
Or,
Right.
or you do it June and then July.
But the good part is, if
Well, it
you're.
depends on whether it's a calendar year or
Right.
fiscal year.
Right.
What do you
That's-
use, calendar year?
Uh,
I think you probably do.
It's calendar.
Yeah, okay.
But if you're investing $1,000 into prevention,
And that's really where we want to go, centralize. We want to better align public health policy with Medicaid policy in this space. and
This
that
will
is-
really benefit our children.
There's no doubt about it.
But to pay more because they don't have the cap and now with sealants and good care, they can, as adults, they're entering adulthood with very different oral health and necessary. So I see children are really the big beneficiaries here.
They are, and we're further aligning with the oral health plan in the state that BDH owns in providing additional education to the dental providers so that we can incentivize the right behavior, because I think it is prevention that will reduce the costs later on.
Then we have the pharmacy, and that's the over-the-counter, which you had rolled out before.
Yes. Do you have any questions on that?
Well, I don't know who's going to oppose this.
I don't know the answer.
My only comment was like, if it partly do be done because it's available through the SNAP benefit, but if the SNAP benefit is being reduced, is that?
They will get it through the medical benefit.
Oops.
Nutritional supplements we're talking about.
Oh, you're talking about like insure.
Boost, for example.
Boost, okay. All right, clawback. We have to pay it.
Do you want to discuss that further?
No, well, it's just whatever we're told we owe, so I don't think that's anything we have any control over. Eliminate cost sharing.
Right, the BCSR program.
We're gonna hear from the healthcare ombudsman on this.
I have not heard. But this is a Vermont cost share reduction in the state program to assist with premiums. And this represents, Allison, I'll let you, I'm sorry, I'm taking over your presentation. I'll let you pick this.
That's okay. That's okay. So I just want to point out that this reduction is only for a 6-month impact because any changes must occur on a calendar year basis. So this would be effective in January 2024. And VCSR is a state-funded program to reduce out-of-pocket costs for eligible qualified health plan enrollees. And this would help cover the affordability gap for Vermonters on the state exchange within a certain income level. Federal changes in recent years, which have made health plans with lower out-of-pocket costs affordable for Vermonters, the VCSR is no longer efficient use of the state dollars. So this would actually be a savings.
I can see that, it's in parentheses. I'm just wondering if somehow, we're gonna get, we'll hear, obviously.
You will.
In terms of, and then what you're saying is if you have $500,000 of general fund, is this the place where the need is the greatest? It's
Right, I think
really
it was when the program was launched, and I think that the benefits have eroded over time as the subsidies have increased in other areas.
And then S-chip, just match rate.
Correct.
Okay, and then we're done.
So simple.
All right, well, thank you. I think we probably wrapped our head around this as much as we can. So other questions will be in touch, but thank you.
Thank you so much.
Okay, we are going to move on, and we're going to have Vermont Fair and Field Days.